Hello, I-10 coders. Let's review today a few helpful hints from Chapter 14, Infectious and Parasitic Diseases. One of the most important things to remember when coding for infectious and parasitic diseases is that the primary focus is on the organism. Here is a list from your textbook of some common organisms or bacteria that you might come across when coding in this particular chapter. A lot of you are probably familiar with some of these terms, such as E. coli or Listeria, Staphylococcus or just a staph infection, Streptococcus. Most of you have heard of strep throat. That's the Streptococcus bacteria causing that. Let's see, what else is on here? Salmonella. We hear that talked about in the news every once in a while. So again, this is not an exhaustive list, but just the types of things to be familiar with as an example as the organism serving as the primary focus in this chapter. So as an example, when you have a main term for a condition, please remember that the subterm for a specific organism will always take precedence over a generic term such as acute or chronic. Again, the organism will take precedence over a general term. Let's take a closer look at an example. So let's consider the diagnosis of chronic cystitis due to gonococcus. Under the main term of cystitis, you will see that there is a subterm for chronic, and there is also a subterm for gonococcal. So this is where you need to remember that rule that the organism, in this case gonococcus, the gonococcal organism, will take precedence over the general subterm of chronic. So our final code for this particular diagnosis would be the A54.01 and not the chronic route. So no. Again, organism taking precedence over a general subterm. Another thing to keep in mind when coding for infectious and parasitic diseases is what to do when an organism is specified in the diagnosis, so it's been documented by the physician, but it's not listed as a subterm under the main term for a condition. So our previous example, when we found the main term cystitis, it had an actual subterm for the organism. We had that subterm for gonococcal, which took the precedence over the other subterm of chronic. But what if that subterm for the organism, for gonococcal, was not present? In that case, you can refer to the main term infection. So you would just find the term infection in the alphabetic index, or you can go to the actual main term for the documented organism as well and try to make a path that way. But let's consider the diagnosis of candidal cystitis. When we go to the main term of cystitis in the alphabetic index, which is just an infection in the bladder, inflammation in the bladder, if we scroll down through here, we find that there is no subterm for candidal. So when we scroll down through, we can't find the appropriate organism subterm. However, if we go to instead the main term of infection in the alphabetic index, we can find an appropriate subterm that gives us an instructional note here. So when we find candida, it tells us to see candidiasis, the condition of the having the candidal organism. So when we go to the main term then also, still in the alphabetic index here, of candidiasis, you'll see that there actually is a subterm for cystitis. So our final code for this diagnosis is going to be B37.1 65.41, which of course you would still confirm in the tabular list to make sure there are no instructional notes or additional characters to be added. But just knowing that if you have trouble with that first main term, just know you have other routes by going to the main term infection or going to the actual main term of the organism. Let's switch gears now and take a minute to discuss something else from this textbook chapter, and that is the coding and sequencing of severe sepsis. Just like our late effect codes, we are looking at a minimum of 2 codes when coding for severe sepsis. You should first sequence the underlying condition or underlying infection, followed by a code from category R65.2, which is the code for severe sepsis. Now, I'm not overly concerned with coding an example right now for severe sepsis, but I do want you to be sure to know that there is a minimum of 2 codes for those severe sepsis diagnoses, and also to show you that you do have help in the tabular list for severe sepsis. So remember, we're looking at this code, R65.2, over here in the tabular list. And when you do check here, you see a note, actually quite a few notes here, but the first one specifically says code first underlying infection, and it gives you some examples of some underlying conditions. So this is telling us not only to code first something else, but in turn that also tells us that the R65.2 can never be used as a primary diagnosis. It cannot be listed first when you are sequencing for severe sepsis. So again, that underlying condition must be sequenced first. Another item to keep in mind in this chapter is the coding of HIV or AIDS. Code B20 can be assigned for all types of HIV infections. So here's a list of the ways HIV and AIDS are commonly documented in the record. So any of these documentation phrases can be used to pull in this code B20. Please remember that when a patient is admitted for an HIV infection or any complications that are related to that particular diagnosis, related to the HIV or AIDS, code B20 will always be sequenced first. So that's if we're talking about the actual condition or anything that's related to that condition. However, if a patient is being treated for a condition that is totally unrelated to the HIV, so let's say a patient came in with a fracture, an injury that was totally unrelated to the HIV diagnosis, then you would code the fracture as the primary diagnosis because that's what's going to be treated, right? They might put a cast on an arm or something that's unrelated to the HIV. So you would definitely want to code the fracture first, but you want to make sure to also pull in this B20 code as a secondary diagnosis. This diagnosis could certainly affect the treatment and things to be aware of for the physician and also for reimbursement purposes. So again, the primary diagnosis is going to depend on what is being treated during the admission. If you're treated for HIV or HIV complications, B20 first. If you're coding for something totally unrelated, then the condition will be coded first, but still pulling in that B20 as a secondary diagnosis. We will take a look at an example of this in just a couple of minutes. One last thing to consider with code B20 here. Remember back when we discussed that inpatient admissions, so if we have a condition for an inpatient admission, that we are able to code a condition that is documented as suspected, or likely, or probable. Remember, we're allowed to code those as an established condition in the inpatient setting. Well, B20 is going to be an exception to that rule. So in this case, the provider must explicitly document HIV positive in the medical record before it can be coded to B20. So even if the coder sees an HIV positive test result in the medical record, they cannot code that unless the physician has specifically documented, yes, this patient does have the HIV virus or AIDS. So in this particular case, again, we're going against our general rule. If AIDS is documented as suspected or likely, we cannot code B20. There could be legal or moral implications for using that particular diagnosis code if it is not truly the case. Let's go ahead and code a few exercises together from chapter 14. So in exercise 14.1, we find the diagnosis of acute empyema due to group B streptococcal infection. I want to stop here before we start coding. If you ever come across a word in a diagnosis statement that you are not familiar with, don't ignore it. Don't blow it off. Sometimes a coder, actually oftentimes, you need to do a little personal research if you don't know about something. So for this example, empyema, if you are not familiar with that term, go look it up. It just takes a minute. You've educated yourself for next time and you know what the physician is trying to document here. Then you will have a full understanding of the big picture. But in this case, if you do go look up empyema, if you're not familiar with that term, you will come to find out that it just means pus. Remember, we've got that pi from medical terminology, pus within a bodily cavity. So we have acute empyema due to group B streptococcal infection. In the alphabetic index, we find the main term of empyema. Here you will note the non-essential modifier of acute. So acute empyema is just going to lead us to the code J86.9. If you scroll down through the subterms here, you will find that there is no subterm for streptococcal. So now that we have at least addressed the empyema, what do we need to do? We need to act and always check the tabular list. So when we go back and look up J86.9 in the alphabetic index, you will notice at the category J86, there's an instructional note. Use additional code B95 through B97 to identify the infectious agent. The infectious agent we know is group B strep. So it's telling us, you can go look up streptococcal or streptococcus in the alphabetic index, but here it's telling us where to go in the tabular, B95 to B97. So it's not a large range of codes, so you can turn directly to that range of codes in the tabular list. And when you start scrolling down here, you find the code B95.1, Streptococcus group B as cause of diseases classified elsewhere. This is the cause of the acute empyema. So at the end of the day, we will have these two codes, the J86.9 for the acute empyema, and then following the instructional note to get to B95.1 to pull in that organism, that group B strep. Also in exercise 14.1 this week, we find the diagnosis of enterococcal septic shock due to acute postoperative peritonitis. The surgery was performed during the same admission. So this is a postoperative infection from the surgery we had during the same admission. So here we're looking at this diagnosis statement. This is pretty long and complicated, especially for this beginning I-10 class. But if you choose to move on into the intermediate coding class, if you have plans long term to become a coder. These are the type of things we will be playing with in HIMT 2275. But for this week, I wanted to walk you through this one a little bit because we come to find out that these two itty-bitty lines of documentation, we actually end up with 4 codes. So here my first instinct would be to go to the septic shock. So if we start in the alphabetic index with the main term shock, post-operative, septic subterms, this leads us to T81.12. Then when we go check the tabular list, we end up pulling in a placeholder X and this 7th character of A for initial encounter. This is the initial encounter for this post-operative shock. Also in the alphabetic index here at T81, we see an instructional note. Code first, underlying condition. That's why I have the infection listed first up here. So we find this code for that underlying condition, which is the post-operative infection, by going to the main term infection with subterms post-operative wound, surgical site, organ and space. When you look in the alphabetic index, there are just a few subterms there, and this is the most applicable since we're talking about the peritoneum here. That leads us to code T8143. Again, we check the tabular. We end up with another placeholder and A again for initial encounter. So here's our first diagnosis, the underlying infection which caused the septic shock. Now we're going to provide some more specificity. So what type of sepsis is this? We're having the septic shock. Well, what is that underlying organism with the sepsis? So here we just go to the main term sepsis with subterm enterococcus, which leads us to A41.81. And here we're further going to describe the peritonitis, that post-operative infection, as location, the peritoneum, peritonitis, acute, leads us to K65.0. So again, we end up having 4 codes for this particular procedure. If you don't remember, the peritoneum, that is just it's just a membrane that lines the cavity of the abdomen. It sort of covers the abdominal organs. So that's, if you want to get a visual in your head, that's what we're dealing with here. Now let's go ahead and take a look at 2 different HIV-related diagnoses to note how the treatment will affect sequencing when it comes to use of that B20 code for HIV and AIDS. So our first example here, I'm in exercise 14.2. We find candidiasis of esophagus, opportunistic, secondary to AIDS. Opportunistic just means as a result of the AIDS, this candidiasis was able to take the opportunity to move in and develop because the immune system has been suppressed due to the AIDS. So that's what opportunistic means. But here, since the condition is AIDS-related and secondary to an AIDS-related condition, our B20 code will be listed as the primary diagnosis. And we will then pull in the candidiasis of the esophagus as a secondary code. Again, the focus is on the HIV or an HIV-related condition, which is clearly documented here. Now, let's take a look over here. Acute appendicitis, admitted for appendectomy, this is important. Kaposi sarcoma of skin of chest due to HIV. So again, the key for sequencing here is where is the treatment directed? If it's directed at an HIV-related condition, B20 will always go first as your primary diagnosis. If the treatment, in this case the appendectomy, is focused upon something other than the HIV-related condition, then we will code that condition first and then still be sure to bring in that B20 code as a secondary diagnosis. So here, the appendicitis has nothing to do with an HIV diagnosis, and that's what the admission is for, is to address the appendicitis through an appendectomy. That's going to be sequenced first, followed by the HIV and the Kaposi's sarcoma of the skin. That wraps up my Chapter 14 helpful hints. So happy coding of your infectious disease exercises, and see you next time.